Committee will come to order. Good morning. Today we are considering two healthcare bills that advance two important priorities for our committee, making sure more people have access to high-quality, patient-focused healthcare and protecting Americans from the harmful impacts of the Affordable Care Act. Our first bill is Dialysis Patients Demonstration Act, bipartisan legislation championed by Congressman Young and Blumenauer. This bill will help Americans suffering from end-stage renal disease, or ESRD, chronic kidney disease that can be debilitating and costly. More than 650,000 Americans receive dialysis each year to treat end-stage renal disease. Congressman Young's bill establishes a voluntary ESRD integrated care program within Medicare, where these patients can access the high-quality, coordinated care they need. This will significantly improve healthcare outcomes for Americans with ESRD, save them time and money, and help lower costs for Medicare. Our second bill is H.R. 954, the Co-op Consumer Protection Act of 2016, authored by Congressman Adrian Smith. This bill exempts Americans from the Affordable Care Act's individual mandate tax penalty if their health insurance was terminated due to the failure of an Obamacare co-op. Here's the situation with these co-ops. When the Affordable Care Act became law, it used taxpayer dollars to create 23 co-ops as federally backed nonprofit health insurance companies. After 4 years and billions of dollars in taxpayer-funded loans, all but 7 of these co-ops have failed. So let me say that again. Out of the 23 original co-ops, only 7 are left standing. Hundreds of thousands of American families depended on these co-op plans for their health insurance. Now, the plans they purchased have been terminated through no fault of their own. And if that's not painful enough, these Americans, perhaps many more, if additional co-ops collapse as predicted, could be forced to pay that individual mandate tax penalty for not having coverage. That's just wrong. Through our work on the Healthcare Reform Task Force, Ways and Means Republicans have put forward a consensus plan to repeal and replace Obamacare. Our plan will bring relief to all Americans from the individual mandate and its tax penalty. As we work to turn our plan into legislation, it's only right to offer immediate relief from this tax penalty to Americans who lost their insurance or lose it in the future due to the colossal failures of the co-op program. We have an opportunity to do that today with Congressman Smith's legislation. I want to thank all the members who worked hard to craft the patient-focused legislation before us today. It's my hope we can pass these bills with the strong bipartisan support they deserve. This time I recognize the ranking member for an opening comments he may have. Mr. Levin.
Thank you, Mr. Chairman, and hello to everybody. Welcome back. Let me first comment on the first bill, 5942. More than 640,000 Americans today are living with kidney failure, otherwise known as end-stage renal disease, and more than 80% of them are covered through Medicare. This bill would establish a new facility-based ESRD demonstration program within Medicare. This demonstration would help make sure that patients receiving dialysis are receiving the high-quality, integrated, and coordinated care that they need by a team of physicians and other healthcare providers. And since this demonstration program would be within Medicare, it would require this team to provide their dialysis patients with all the benefits entitled under Medicare. I commend those who've worked on it, including especially on our side, Mr. Blumenauer, for months and maybe a few years of work on this. Now let me comment on the second bill. There's a new survey that shows, it comes from the Centers for Disease Control and Prevention, that the number of uninsured Americans has fallen to just 8.6%, the lowest level ever recorded in our country. 8.6%. And part of the legislation that we passed relates to the individual mandate. And my concern about this bill, in part, is, as evidenced by the chairman's opening statement, it's part of an overall attack on ACA. And to bring this bill up as part of a broadside attack on ACA, I think raises deep concerns on our side. Let me just speak in some detail about this. ACA provides a special enrollment period for individuals who were impacted by the closure of co-ops, so that they do not have to wait until the end of the year to enroll in a new plan. Likewise, in instances when purchasing a new plan would be financially difficult, these individuals could also apply for a hardship exemption from the individual mandate penalty. When we discovered that this bill was coming up today, and it was only a few days ago, I sent a letter to Jack Lute, to the Secretary of Treasury, and to the Secretary of HHS, and I would ask that the copies of this letter and the response be distributed, Mr. Chairman.
Without objection.
If that could be done right now, because I want to refer to it. And I gave you, Mr. Chairman, a copy of the letter. I just received the response tonight. This is the letter that I sent on the 6th to the Secretary of the Treasury and to HHS, to Sylvia Burwell. And I asked in this letter, having just learned that the bill was coming up, I asked for answers to a number of questions. In which states have co-op plans closed in the middle of a coverage year? How many individuals have been affected by these closures in each state? How has the administration assisted individuals whose co-ops closed mid-year? Do you know whether and how many affected individuals re-enrolled versus became uninsured and made an individual responsibility payment? And lastly, would such individuals be able to receive a hardship or affordability exemption from the individual responsibility fee? So I received just late last night a response, and they had very short notice. They closed by saying, we continue to work with departments of insurance to communicate with consumers and enroll them in new coverage. The Affordable Care Act is working, having contributed to a record low 8.6% uninsured rate and 20 million more Americans with coverage, and the slowest growth in the price of health care in 50 years. Mr. Chairman and colleagues, we need to obtain further information from the two secretaries about exactly what has happened to anybody who lost coverage through the closure of a co-op, and at this point we do not have that information. And I hope that we approach this bill knowing the need for much further information, surely before this bill might ever come up on the floor. And I close with this. I think for those who favor this bill or come from states where there were closures of co-ops, I think you're making a serious mistake by essentially using this bill as part of your overall attack on ACA. You've tried to repeal it 50-some times or dramatically undermine it. And if you paint this bill as a further effort to do so, I think you're going to make sure that it doesn't become law. So I urge everybody, as we consider this, to take a look at these two letters, and I ask, Mr. Chairman, that it be put in the record.
You betcha. Thank you. Without objection. Our first order of business, H.R. 5942, the Dialysis Patients Demonstration Act 2016. This time I'd like to recognize the bill's sponsor, Mr. Young, for an opening statement. Mr. Young.
Thank you, Mr. Chairman. As many as 25 million Americans currently struggle with chronic kidney disease, a condition that significantly reduces kidney function over time. Many of these individuals are unaware of their condition, and they won't know anything is wrong until the disease progresses into kidney failure, a serious stage of the illness often referred to as end-stage renal disease, or ESRD. Each year, an estimated 650,000 patients with ESRD must receive dialysis treatment in order to stay alive. We know these patients are vulnerable to a host of accompanying health complications, such as diabetes and high blood pressure, which will require extra medical care, attention, and coordination. Unfortunately, our current system for providing care on many occasions can be fragmented. I know. I've visited dialysis patients in multiple locations around my state of Indiana. This fragmentation makes care coordination increasingly difficult, as ESRD patients must navigate between multiple physicians' offices, dialysis facilities, and hospitals, all while adhering to various plans of care. We can do better. We know these patients would benefit, and the Hoosier patients I've met with tell me they could benefit from a more comprehensive approach to treating all of their medical needs in a way that lowers costs, reduces hassle, and results in better health outcomes. Now, that's why we've introduced the Dialysis Patients Demonstration Act, which establishes an integrated care demonstration program where interdisciplinary teams, led by a nephrologist, provide holistic management for all of the dialysis patients' healthcare needs. By improving care coordination for end-stage renal disease patients, we can not only reduce healthcare costs, but allow our most vulnerable individuals to live healthier, more active lives. This program utilizes the dialysis facility as a central command point for patients to access coordinated healthcare services, sparing patients time, money, anxiety, and multiple trips in and out of various providers' offices, all while producing better health outcomes. Patients will not only receive all the benefits entitled to them under Medicare, but they'll also have the opportunity to access additional services, such as transportation services, dental, and vision care, to help them better achieve their treatment goals. Now, this practical approach to care delivery has the potential to significantly improve health outcomes, reduce hospitalizations and readmissions, decrease program costs, and increase quality of life for hundreds of thousands of dialysis patients in Indiana and, of course, beyond. I want to thank my Democratic colleague, Congressman Blumenauer, for his exceptional leadership and partnership with me on this initiative, as well as Congresswoman Kathy McMorris Rogers and Congressman Tony Cardenas, our partners on the Energy and Commerce Committee, for their continued support. Also, Jamie Light on my staff and the staff of Representative Blumenauer, committee staff. Finally, I want to thank the Hoosiers on the ground who've helped educate me about the importance of this initiative, who've shared with me that we can do better, who've told me they deserve better, and you know what, they're right. I just don't see how we can improve the lives of our people in meaningful ways like this without direct interaction with those receiving the services. So in the end, I give a great shout out to the people of Indiana, the people of Oregon, and others who have educated about the importance of making this change. I urge all of my colleagues to support this legislation, and with that, I yield back the remainder of my time.
Thank you. At this time, I recognize Ranking Member Levin or his designee for an opening statement.
Thank you, Mr. Chairman. You know, I think we should be happy with this work. It doesn't undermine healthcare reform, and it surely doesn't privatize or undermine Medicare. It goes in the opposite direction. And so I'm very happy to yield the balance of our time to someone who has labored hard to bring to each of us the reality that I think we know from our own experiences either directly or indirectly. Mr. Blumenauer.
Thank you, Mr. Levin. I appreciate your courtesy. It wasn't actually years. It's just been months, but it seems like years, I will say. And I appreciate the kind words from my colleague from Indiana. He's had a few things on his plate this year, but being willing to invest the time and energy to work through this. It is an issue that has impacted me with greater force. I watched a stepfather struggle with dialysis at the end of his life. I have my chief of staff donated a kidney to her sister, and they celebrated their 25th anniversary. But I really, until this last year, didn't appreciate the complexity that's involved with kidney health and the opportunity to do it better. We have hundreds of thousands of people who are literally tethered in the dialysis center 3 times a week, every week of the year. And it is hard on them. It is literally draining. The logistics are complex, and they are, as Congressman Young pointed out, some of the most complex health problems that have resulted in the potential kidney failure. I am hopeful that we will be able to embrace this very targeted pilot project to be able to see if we can coax more value out of the time and energy they invest and with the resources of these dialysis centers to be able to go beyond, to really make this a medical home for them, to be able to give them a higher quality of life. And I hope that it's part of what we might be able to do at both ends of this equation, both upstream to prevent people from getting to this condition in the first place. The more that we learn, the more that we develop resources, and candidly, downstream, because we're in a situation where in some cases, hopefully there is transplantation, which we do not fully realize the potential, and we don't do a good enough job taking care of people, both the donor and donee, and for those folks for whom the end has come. Some of you know I've done a little bit with end-of-life care, being able to make a transition for comfort. There's a broad continuum here that I think we need to look at. This pilot project, I think, is a step in the direction of coaxing more values. I think ultimately it will save more money for the taxpayer. But these are not cases. These are people. And I think this is a mechanism to help people in ways that will give them better care and make them more comfortable and simplify their life in an extraordinarily difficult set of circumstances. I appreciate the opportunity for us to have a session on it today. The reference, Mr. Young, to Jamie Light on your staff, I would say something about Kristen Donheffer, who feels like this is probably a college thesis that she's been working on. We've had tremendous support from minority and majority staff. Nick Ulecki, who is very patient. Melanie Grogan, Melanie is around here, who's also gone above and beyond the call, to be able to meet with people for whom these are high-stakes issues. There's a lot of professional pride involved. There's a lot of work that people have done over time. There's a lot of money involved. So I think it was worth the time and attention, and I appreciate the opportunity for us to move this forward. I yield back.
Thank you. The committee will now proceed to consideration of H.R. 5942. Without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in the nature of substitute, which was distributed in advance, along with the green sheet explaining it. Without objection, the amendment in the nature of substitute shall be considered as read, open for amendment at any point in the considered base text for purpose of amendment. I'll now turn to Emily Murray, the Staff Director, Subcommittee on Health, to provide the technical description of the amendment in the nature of a substitute, with an emphasis on the changes made since introduction. I ask the members hold their questions until after her presentation. Ms. Murray.
Thank you, Mr. Chairman and Ranking Member Levin. H.R. 5942, the Bipartisan Dialysis Patients Demonstration Act of 2016, was introduced by Representatives Todd Young and Earl Blumenauer on September 7, 2016. This bill aims to help Americans suffering from end-stage renal disease, or ESRD, through establishing a voluntary integrated care demonstration program where interdisciplinary teams led by a nephrologist working with other providers, such as through the use of dialysis facilities, provide high-quality coordinated care. This integrated care model is open to facilities and providers of all sizes through the availability of partnerships and coordinated efforts. In addition, under this legislation, patients would continue to receive all benefits they are currently entitled to, as well as access to additional services with the ability to opt out or seek care outside of the organization. As noted on the green sheet, the Chairman's amendment would further ensure that proper oversight occurs of the marketing and assignment practices of each organization. The amendment would do this by adding that the Secretary of HHS shall oversee such practices not just when an organization seeks approval, but also when it's seeking renewal. Mr. Chairman, that completes my walkthrough, and I'm happy to answer any questions.
Thank you. Are there any questions about the amendment in the nature of a substitute? Dr. McDermott.
Mr. Chairman, could you tell me when we had the hearing on this bill?
On the ERSD bill, hold one second.
I was interested in who the witnesses were.
Yeah, Dr. McDermott, my memory may be flawed, but I keep thinking this was included in our congressional hearing on member health care ideas that were brought forward to the committee. In fact, at the hearing you were ranking member.
So it was a member who testified on it, but nobody involved in the industry?
That's my recall of the day, yes.
Thank you.
Although I'll tell you, my view is the industry's been deeply involved in this. If you look at the legislation, I'll tell you, this is complicated process, a very thoughtful delineation of how the partnerships works, the patient protections, the options for the care, and sort of the accountability. Really, just reading again through it last night, this is a very good piece of legislation. So. Any others wish to ask a question? Does anyone wish to strike the last word? Dr. McDermott, yes, sir.
Mr. Chairman, Tom Marino and I are the chairs of the Kidney Caucus in the Congress and have been so for the last 10 or 12 years. Tom has chronic kidney disease, and I come from the city where dialysis was developed and where it was given to Senator Magnuson and put into Medicare. People wonder how come it's in Medicare. Well, when it was developed, there was no national health plan. The only national program there was Medicare. So they stuck ESRD into that. Now, I appreciate what Mr. Young and Mr. Blumenauer are trying to do here. It's clear that the treatment of these patients has changed over time, and we have more ways in which we can deliver care. And there are lots of varieties, but it's been hard to get a hearing in this committee. We've been here for 6 months, and this bill comes up right as we're leaving the last door. Now, kidney patients are among the most sickest and vulnerable patients of Americans. Since '72, we've made a commitment through the Medicare program to take care of them. Medicare is a lifeline for hundreds of thousands of people who've been left out in the cold by the insurance industry, particularly before the Affordable Care Act. Because we made that commitment to these patients, we owe it to them to ensure that their care is of the high quality and delivered efficiently. And I recognize the bill is intended to help us achieve that goal. However, I believe it is something I'm not going to support today, and I'll tell you why. We face a recurring problem on this committee. Time and again, we are presented with legislation that deals with important and complex issues. Time and again, we have no hearings, no debate, and frankly, no idea what's going on until it's dropped on the desk yesterday. That's when people got access to the final text. That's why we're considering this bill is just an example of the broken process in this committee. The version of this bill was introduced in June. That draft drew significant opposition from some of the people who know this issue much better than anybody on this dais, including me. I'm a physician, but there are people out there who do it on a daily basis who know more. The nonprofit kidney care facilities worried this bill would unfairly benefit the big for-profit companies at the expense of the small providers. The non-providers warned us that they would not have the capital necessary to bear the risk and participate in the coordinated care models under the bill. If that turned out to be the case, the bill would basically funnel money to the big guys while shutting out the little guys, the nonprofits. As someone who's seen this historic role of the Northwest Kidney Centers in Seattle, they played a pioneering role as a nonprofit in producing what we have today in this country. And I think it's important to listen to the nonprofits. They may not have the big megaphone as industry giants like DaVita and Frenzius, but they know what they're talking about. And when they raise concerns about the bill, they deserve to be heard. I recognize we're now looking at a substantially revised version of the bill because of their arguments and when it got circulated out there without public hearing, all this is behind closed doors. And they said, we don't like this, and so some changes were made, I guess. And the changes have been made to resolve some of the concerns. However, we didn't get the text until yesterday. None of us have had time enough to evaluate it carefully or discuss it with experts. I sent it out last night to Northwest Kidney Center and said, give me your best estimate, and they, were 3 hours behind, so they had a little bit of time to look at it. But this is a failure of the committee process. This bill doesn't need to be run through here right now at this speed. It could have been started May, June. We've been around here, did nothing on this committee. Nothing. And yet we're running this bill through here and saying we know what we're doing. Well, in fact, the bill's known locally outside this hall as a DaVita bill, because they see it as what it will do is it will make it impossible for small operators to keep in. And for that reason, I'm going to oppose it.
Does anyone else wish to strike the last word? Mr. Blumenauer, you're recognized.
Yeah, I have deep respect and affection for my friend from Seattle, and I would be happy to have hearings on it, but I wanted just 3 things for the record. Number one, Northwest Kidney Center was one of the groups that I met with on several occasions who had a copy of the bill. The latest bill simply includes technical clarification from OMB and CBO, or CMS, excuse me, that were clarifications that were sought by folks to make sure that that people understood. So there was absolutely no substantive change, and they had received a copy of it from us earlier, Jim. I also want to point out that this is a limited-term pilot project to find out if it works, to find out if we can provide greater value, better service for people. And from the very beginning of my meetings with a wide group of stakeholders, I made it clear that it may not work for everybody. That's part of what we are doing in this committee as we continue to make sure that we're getting the most value out of our healthcare system. Not everybody is going to have their exact role and make all the money they make now and make it the same way. We're looking at ways to add value. And if we can add value in some limited cases, I think we do that. And some people may be affected differently. That's why it's a short-term pilot project so that we can evaluate the impact of it. And so I wanted to clarify that. Thank you. I yield back.
Thank you. Does anyone else wish to strike the last word? Are there any amendments to the amendment in the nature of a substitute? If there are no amendments, questions on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Those opposed, no. Opinion of the chair, the ayes have it. The amendment in the nature of substitute is agreed to. I'll now recognize Mr. T-Berry for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 5942 as amended to the House of Representatives.
Questions on favorably reporting the bill H.R. 5942 as amended. All those in favor signify by saying aye. Aye. Those opposed say no. No. In the opinion of the chair, the ayes have it. The motion is agreed to, and H.R. 5942 as amended is ordered favorably reported to the House. Without objection, I ask the staff be authorized to make technical and conforming changes to the bill. The members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our next order of business, H.R. 954, the Co-op Consumer Protection Act of 2016. This time, I'd like to recognize the bill's sponsor, Mr. Smith of Nebraska, for an opening statement.
Thank you, Mr. Chairman. Thank you for calling up the bill today, the Co-op Consumer Protection Act. This is a short, simple bill with a basic premise. If you are a consumer who complied with the ACA's individual mandate by purchasing health insurance through one of the consumer-oriented and operated plans, or co-ops, created under the law, and your plan was terminated mid-year by the failure of that co-op, you shouldn't be liable for the individual mandate for the remainder of that calendar year. We've already had a hearing on what happened with the co-ops, so I won't spend a lot of time rehashing that history. In short, $2.1 billion, largely in the form of startup insolvency loans, was distributed to approved co-ops. Now, 16 of the 23 co-ops, which received $1.7 billion of those dollars, have closed or are in the process of closing, with the remaining 7 also struggling to remain solvent. The first of these co-ops to close was Co-Opportunity Health, which provided plans covering 120,000 Nebraskans and Iowans in 2014, before being taken over by the Iowa Department of Insurance late that year. Co-Opportunity plans were wound down in the first quarter of 2015, and consumers were given an opportunity to select a new plan through the exchanges. While health providers in Nebraska and Iowa were made whole for services provided to Co-Opportunity plan holders through the state's guarantee funds, consumers and the remaining insurers in the 2 states are now paying back the guarantee funds for those costs. Similar situations have played out in other states covered by collapsed co-ops, including states like New York and Illinois, where plan holders have lost coverage mid-year. When Co-Opportunity collapsed, I heard from nearly 300 constituents with concerns about what this change meant for them, including concerns about penalties for lapses in coverage, about having to cover deductibles twice in the same year, and about seniors very close to Medicare who were healthy and simply didn't see the point in dealing with a brand new insurer for a short time before transitioning to Medicare. I've previously shared the story of Pam Weldon, a constituent from Minutair in my district. She approached me because she had lost coverage 3 times in a little over a year. First, the plan she had prior to the ACA, which covered her pre-existing condition, was canceled. In its place, she chose a plan from Co-Opportunity Health, which Co-Opportunity phased out after 1 year in an effort to remain solvent, and finally a second Co-Opportunity plan was terminated when the co-op was wound down entirely. Another constituent, Melissa Lordeman of Hardington, wrote to me the day after Christmas in 2014, concerned that their Co-Opportunity plan was ending in early 2015, and that her family, including her child with medical needs, would find themselves paying a deductible twice or paying the individual mandate penalty for part of 2015, neither of which they could afford. While both these situations were worked out with minimal disruption, it is only fair that we reduce the impact further for these families and ensure that if any other co-ops close, that families struggling to make an unexpected decision about health insurance mid-year don't have individual mandate penalties to worry about as well. I know there are diverse views about the individual mandate on both sides of the aisle. The bill isn't about that. It is about ensuring consumers aren't caught in the crossfire, and I ask for your support. Thank you. I yield back.
Thank you. At this time, I recognize Ranking Member Levin or his designee for an opening statement.
Thank you, Mr. Chairman. I've already laid out the background for this and the provisions for special enrollment periods, as well as hardship exemptions and the lack of data. I also think it's important to go back and look at how there were efforts here to undermine the ability of co-ops to function. So I intend to ask a series of questions to you, Mr. Bartholt, about what we know in detail about the impact of the failure of co-ops. Let me yield the balance of our time to the ranking member on the subcommittee, Mr. McDermott.
Thank you, Mr. Levin. We are today marking up a solution to a hypothetical problem. In theory, there could be co-op enrollees who didn't maintain minimal essential coverage when their co-op folded last year. It is plausible that some were on the hook for a small penalty because they chose not to sign up during special enrollment periods offered by the administration. But we don't actually know. I think that Mr. Levin has pointed out the letter coming from HHS and from the Treasury says they don't know yet. We have no evidence to even guess how common this scenario may actually be. We have no data as to how many people may have been affected, and we certainly don't know how a critically underfunded IRS will administer the exemption retroactively. In other words, we aren't sure what the problem is, who is affected, or how to solve it, even if it exists at all. Yet, here we are this morning preparing to push this bill to the floor without so much as a hearing once again. It isn't a very good way to run the Ways and Means Committee, but it is a good way to spread misinformation about the Affordable Care Act and the co-op program. And I'm going to have to tell you a little history again. Here's what this bill is really all about. Don't believe the Republicans when they pretend to care about consumers harmed by co-op closures. Republicans wanted the co-ops to fail from the start. For years, they systematically underfunded the program, undermined it, and made it virtually impossible for a co-op to succeed. Let's look at what they did. In 2013, under Republican leadership, Congress slashed the funding for loans and grants to the co-ops by nearly 2/3. This devastated the program during its early days and denied consumers access to dozens of potentially new choices in the marketplace. It didn't stop here. In 2014, the Republicans inserted a rider in the Cromnibus bill that blocked the administration from shifting discretionary funding into ACA's risk corridor program. This was a deliberate effort to destabilize insurance like these co-ops who were taking on new populations under the ACA. The Republican rider cut risk corridor payments to 1/8, 12% of expected levels, creating unpredictability and devastating small insurers. With the deck stacked against them, many fledgling co-ops struggled. They were victims of the Republican attack that they simply couldn't withstand. The Republicans knew what they were doing. They created risk management measures in 2003. When they wanted to be sure that the drug bill worked for the drug companies, they generously funded those risk corridors. The Affordable Care Act didn't receive the same loving treatment. And sadly, that shouldn't be any surprise. After 65 meaningless repeal votes, we've had people talking around here about the Republican plan for health care for this country since 2009 or 2010 when the bill passed. That's 6 years, and there's nothing on the table yet. So after 65 meaningless repeal votes, numerous frivolous lawsuits, countless sham hearings, and a year of deception, it becomes hard to take what the Republicans say about health care at face value. And as they cry the crocodile tears today, this morning, about the plight of the co-op consumers, it's impossible to take them seriously. If they cared, they wouldn't have destroyed the co-ops when they were born in the crib. They stopped feeding them at the beginning, and they took away their food when they were 2 years old, and now they say, look at this child has just died. Oh, isn't that sad? It's all a sham. They want to get rid of the Affordable Care Act. That's what this whole bill is about.
Thank you. For the record, we did have a co-op hearing November 3rd of 2015 where this issue was discussed at length. All funding measures have been signed in this issue have been signed by President Obama. And without objection, I'll introduce a letter I received today from the Small Business Entrepreneurship Council that talks about H.R. 954 as a solution to the unfair situation that has been thrust upon many small businesses and self-employed individuals through no fault of their own. Without objection, it will be entered. The committee will now proceed to consideration of H.R. 954 without objection. The measure will be considered as read and open for amendment at any point. This time I offer an amendment in the nature of substitute which was distributed in advance, along with the green sheet explaining it. Without objection, the amendment in the nature of substitute shall be considered as read, open for amendment at any point, and considered base text for purpose of amendment. I'll now turn to Tom Bartold, the Chief of Staff for the Joint Committee on Taxation, to provide the technical description of the amendment in the nature of a substitute, with an emphasis on the changes made since introduction. I ask the members hold their questions until after his presentation. Mr. Bartold.
Thank you, Mr. Chairman, members of the committee. You have before you two joint committee documents, JCX 68 and 69, which describe the underlying legislation, H.R. 954, and the chairman's amendment, the nature of a substitute. By brief overview, under the Affordable Care Act, individuals are required to maintain minimum essential coverage or pay a tax for those months when they are not so covered. For individuals who have purchased such coverage through co-ops and then the co-op has failed such that they have lost their coverage, this legislation as amended would provide an exemption from the minimum essential coverage requirement for the month in which they lose coverage and for the remainder of the calendar year, and it would be effective for years after 2013. The significant changes in the chairman's amendment, the nature of a substitute, were to change the effective date to years after 2013, and the underlying legislation had provided that there would be an exemption from minimum essential coverage for those who lost coverage in the last quarter of a year for those months plus the ensuing calendar year. As amended, the exemption is provided for the month in which coverage is lost and the remainder of the current calendar year. Members, that concludes my description of the legislation before you. Happy to answer any questions that you might have.
Thank you, Mr. Bartold. Are there any questions? Excuse me, are there any questions about the amendment in the nature of substitute? Mr. Levin.
Mr. Bartold, in how many states have co-ops closed?
There were 23 co-ops. There are 7 that are continuing in operation, 16.
And in which states?
Let's see. New York, Colorado, South Carolina, Arizona, Kentucky, Utah, Tennessee, Michigan, Nevada, Louisiana, Oregon, Ohio, and Illinois, and Connecticut.
Do we have the data on how many there were in each state?
Co-ops or people enrolled?
Individuals.
For co-ops that ceased operation prior to 2016, and that was, let's see, 1, 2, 3, that was 12 of the ones, or that was 13 of the ones that I noted. Approximately 625,000 individuals had received coverage through those co-ops in those states, and for co-ops that have that are closing, essentially effective next year because they've stopped taking enrollments, roughly 100,000 individuals, Mr. Levin. So the total between the two would be close to 750,000 individuals.
And in each state, as to each co-op, do we have the data on how many of them sought special enrollment?
I do not have that information, and I'm not sure if it's currently available.
Have you inquired?
Yes, we have tried to seek information about to be more specific about what people have done in terms of replacing lost insurance.
And you've inquired of whom?
I'll double check. I'm pretty confident my colleagues have checked with the Center on Medical Statistics. I can check for other sources that other inquiries that we've made. I'll report back to you, sir.
Could you do that as soon as possible?
It certainly will, sir.
So at this point, we don't know how many people took advantage of the special enrollment period. Do we know how many applied for hardship exemption?
Again, we do not know that.
And do we know how many paid a penalty?
For the most part, returns for those years have not been completely filed and calculated. We also do not have an account on that. Our estimates of the revenue effects that we reported to you on JCX 69 are based on estimates that my colleagues worked out with the Congressional Budget Office based on income profiles of people who purchase insurance options for other coverage in states in which they had purchased the insurance. But they are, as always, estimates, sir.
So these are estimates based on projections, not on actual facts.
They're estimates based on, well, the base facts that we start with are how many people were covered under these plans. And then what the committee asks us to do is make projections for prospective years about what are the likely outcomes. We start with as hard data as we can find, and then we base projections of growth of coverage, what's going on in the different insurance markets in the different states, what options are available to individuals.
And the projections include how much the penalty would be?
Yes.
Can you make all that available to us?
Well, essentially we've made available to you the penalty losses in our revenue estimate that we reported in JCX 69. The reported loss over the budget period of $4 million really has two components. It's loss of penalty for failure to comply with minimum essential coverage, less some modest effects in terms of outlay savings, because for low-income individuals, they would be eligible for some of the exchange credits, but if they choose to remain uncovered, those credits would not be paid out. And so that's the net effect that's reported in the estimate that we've presented to the committee.
Mr. Smith, you're recognized.
Thank you, Mr. Chairman. I would like to add a couple things here. On the budget issues that were discussed, I think it's important to note that the authors of the ACA promised that this component would be budget neutral, and the appropriations language that was fashioned following that merely just reinforced the promise of budget neutrality. And so I'd like to ask for unanimous consent actually to submit for the record a memo from CMS from April 11th, 2014, outlining exactly the budget neutrality issue and that payments would be made on a pro rata basis.
Without objection.
Thank you, Mr. Chairman. And I think it's absolutely important to emphasize the fact that, of course, there were a lot of promises that were made, but among them was that this would be budget neutral, and we've seen that apparently the components of the entire co-op program were not able to deliver that budget neutral nature of the program. Let me also, for the record, outline what the individual mandate penalties are. For 2014, it was $95 per year per person, remember, or 1% of income. 2015, it is $325 per year per person, or 2% of income. 2016, $695 per year per person, or 2.5% of income. 2017 and future, $695 indexed for inflation and rounded to the nearest $50, or 2.5% of income. These are significant penalties. I would hope that innocent individuals seeking to do the right thing, to be responsible citizens, to have coverage, would not be penalized simply because the plan that they found themselves with, maybe even against their wishes, but they found themselves with a plan that was then canceled. Thank you, Mr. Chairman. I yield back.
Thank you. Are there any other questions about the amendment? Mr. Becerra, you're recognized.
Thank you, Mr. Chairman. Mr. Bartow, let me make sure I'm clear on how this works. As some of these co-ops that provided health insurance coverage went under, those individuals that had their insurance plans through these co-ops were given an opportunity through a special enrollment period to select a different plan?
That's correct, sir.
Okay, so that implies that there were other health care insurance plans available to individuals who had their insurance through these co-ops?
Well, that would depend upon the availability within the area.
Right, but there had to be other options for them to enroll in if they're going through a special enrollment process.
The existence of an enrollment period doesn't necessarily mean that there would be plans, but as a general matter, yes.
Are you aware of any state where a co-op has gone under where a plan was not available?
Where there wasn't another option? I'm not sure. I'll check to see if there was such a case.
Okay. So my understanding is that there were other plans available. In the case of individuals who are modest income, were there options for folks who had modest incomes who claimed that having lost their insurance through this co-op that they would suffer hardship if they had to go into a different insurance plan?
One of the exemptions Mr. Becerra provided under present law is if someone has lost coverage, an individual may be determined by the Secretary of HHS to have suffered a hardship with respect to the capability to obtain coverage.
So in that case, that individual who loses his or her insurance through the co-op and would find it a hardship to try to secure a different insurance policy can seek that exemption and not have to pay for new insurance coverage.
If the Secretary grants the exemption, that's correct, Mr.
Okay,
Becerra.
so there's an exemption for hardship for those who lose their insurance through the co-op and find it difficult to reinsure through a different plan. By not requiring these individuals who have lost their insurance coverage through the co-op to not have to reinsure, aren't we setting up a two-tiered system where those who are in need of health care, if you need to see a doctor or if you need hospital care and you lose your insurance through your co-op, you're going to have to find other insurance coverage because you need care. If you have a chronic condition, you need care. So you have no choice but to go out there and find an alternative. And if you have a hardship, you might be able to gain an exemption. But if you happen to be healthy, say you're young and you don't right now need health care, it almost gives you an incentive to not seek insurance coverage because you're not ill and you don't need it. So why not go ahead and finish the rest of the year without having to pay premiums? If this bill were to take effect and become law, we would provide an incentive to healthier Americans to not do what their other fellow Americans would do, which is to seek insurance coverage, get insurance coverage because of the requirement that you get it the way we have to get auto insurance coverage, whether we're good drivers or not. And it would put the burden more on other Americans who may be healthy but still purchase their insurance, or certainly on Americans who need health care, and there's a smaller pool now of Americans paying for health care because healthier individuals get to exempt themselves out without paying a penalty. Do you know if we've seen a tendency towards having people who are healthier trying to avoid paying for insurance because they don't need it?
Well, Mr. Becerra, generally part of the economic analysis that goes into the estimates that we in the Congressional Budget Office make related to both coverage and outlays and mandate penalties collected is based on what we see as what some individuals will see as a rational choice to make the decision that you just outlined. That perhaps I'm young, I'm healthy, the insurance is not cost effective for me, therefore I would rather pay the penalty than participate in a pooled insurance program.
And so my sense is this bill would provide the wrong incentives to Americans. We want people to get and keep insurance so that we're all insured the way we do it with auto insurance, not encourage people to go bare without insurance because they think they're invincible and they're young and healthy. And so, Mr. Chairman, I would yield back my time, but simply say I think what we want to do is get better information before we decide to pass a law that might create the wrong kind of incentives when it comes to health insurance coverage.
Mr. Tiberi, you're recognized.
Mr. Becerra, we already passed a law that created the wrong incentives. It's happening right now. I'm going to explode. I'm in a twilight zone. Mr. Barthold, oh my goodness sakes. I can't be the only person who's talking to real people. This is not hypothetical, Dr. McDermott. I don't have a doctor's degree, but it's not hypothetical. This is happening right now. Are you folks not knocking on doors and talking to people? We already see, Mr. Becerra, what you just described, maybe it's not happening in California. Hold on.
The gentleman controls the
31% of American counties have one provider of health insurance. They don't have choices. They don't have choices in my state. In health, co-op in my state. 22,000 people, Dr. McDermott, lost their health coverage. And some of those people had one choice, and they didn't get to go to the doctor they'd been seeing for years because the choice that they had, the one choice that they had, didn't include their doctor, didn't include their hospital for years. We didn't do that. The bill did that. I mean, this utopian view of the Affordable Care Act, and I sat right where Mr. Pasquarello was, this utopian view that the thing was just perfect and the process was perfect is revisionist history.
Was the gentleman you?
Not yet, because my head's about to explode. It's offensive to me, Dr. McDermott. We had a wonderful hearing yesterday. It was not political, that you call this hypothetical when my constituents have a tremendous amount of anxiety because they lost their health care coverage. And their choices are extremely limited. And they're extremely limited because of what you just said, Dr. Becerra. Yeah, Mr. Becerra. And the fact is that we have people who are not signing up. That's exactly right. And insurers who lost coverage. That's why in several of my counties, there's one choice. One, not plans, plan, P-L-A-N. And when there's one plan and one choice, guess what? Less access, higher cost, higher deductibles. This is not fairies and princesses and unicorns, maybe in Seattle, but not in Ohio. Dr. Barthold, this sheet of paper.
Is the gentleman going to yield?
I will, after my question.
Okay.
Dr. McDermott said the issue was hypothetical. Your sheet here, correct me if I'm wrong, when we look out to 2017 in that window, that number appears to me, despite my anecdotal evidence of it not being hypothetical, it appears that you have evidence that it's not hypothetical either. Can you explain that in layman's terms, since you're a lot smarter than I am?
Mr. Tiberi, I'm certainly not smarter than you.
Oh, yes, you are.
As I was explaining, we have hard figures for a number of individuals who were covered under co-op plans that have ceased to exist. We don't have hard data on exact numbers on who lost coverage, did not obtain coverage from another plan, who is paying the mandate. We have made estimates of that based on experience we've had about people paying, choosing to pay a mandate rather than pick up other insurance elsewhere. So the numbers here reflect estimates that are anchored in the scale of individuals who were covered under co-op plans that have ceased to exist.
So you have all these co-op plans that cease to exist. It's been publicly reported that there's an increasing number of counties, metropolitan areas that have limited choices, many with only one choice. In fact, it's almost a third of American counties now have only one choice. It would seem to me that all we're trying to do here is create a little bit of certainty for folks that they're not going to not only lose their doctor, lose their health care, maybe lose their hospitalization, have fewer choices, fewer access, higher costs, but they're not going to get insulted with a $695 penalty, at least, at the same time. Seems common sense to me. I'll yield my last 15 seconds.
I thank the gentleman for yielding 10 seconds there. Some 600,000 or so Americans are within these co-ops. Over 20 million Americans have gained insurance coverage. And so it's been a good program. What we have to do is make it work for everyone, not try to get people not to get insured. In California, we've reduced uninsurance rates by 50%.
Thank you.
So it does work.
Mr. T-Berry's time has expired. Mr. Kind, you're recognized.
Thank you, Mr. Chairman. Mr. Barthold, since we haven't had a hearing specifically on this piece of legislation, I hope you can just clarify a few things for me. Now, the bill before us today is only limited to those individuals who have lost health insurance coverage in a given year due to a co-op going out of business. Is that correct?
That's correct, Mr. Kind.
And then under the legislation, they would then be exempted from the individual mandate or any penalty that they might pay through the duration of that calendar year?
Of that calendar year. So, for example, if you lost coverage in August of 2016, last month, you would be exempted from penalty for the months of August, September, October, November, December of 2016. You would then, for 2017, you would then again be subject to all the general rules of the Affordable Care Act.
And you already pointed out that there is an exemption that's available for hardship cases. That would apply to...
If you apply to the Secretary of HHS, there is a hardship exemption. There's also a 3-month grace period as a general exemption when there's a loss of coverage.
Now, is there any type of distinction to be made, or am I missing something, that why we would allow a rest of the year exemption only for individuals who lost coverage due to the loss of a co-op plan versus an individual who lost coverage due to another private health insurance plan that just decided to withdraw from the exchange?
Well, I think the point here was that the co-ops actually financially is going under. I would have to do some further checking to see what requirements there are under the Affordable Care Act if a non-co-op insurance company were to go bankrupt during the calendar year.
Clearly, I mean, the exchanges are still in a considerable amount of flux. You got some new plans entering them, some plans that are deciding to exit those exchanges and that's just something that we're quite frankly grappling with right now until the market kind of stabilizes itself. Is that correct? That there's new entrants in the exchanges and plans that are exiting the exchanges today?
As reported in the media, there's lots of in and out in terms of what's offered in the exchanges. Yes, sir.
Yeah. And Mr. Chairman, I think it's clearly we knew this was going to be a challenge. Is how do we increase choices? How do we increase competition in these exchanges? And if there's anyone out there who believes that the limitation of choices that we're seeing today suddenly and miraculously materialized after the passage of the Affordable Care Act is deluding themselves. This was an issue that preceded the Affordable Care Act. My goodness, the entire state of Alabama had one blue plan before passage of the Affordable Care Act. And we knew this was going to be a challenge, especially in rural areas, of how do we get more plans in to compete for business. And the fact that we haven't been as successful means there's more work to be done to try to incent more plans to enter the market and to offer those choices and therefore the competition that consumers desire. But I think what's missing and what hasn't been acknowledged is just yesterday there were articles all over our national media that pointed out that the uninsured rate is at an all-time historic low for our country today. An all-time historic low. Per capita spending on health care for individuals is at a 50-year low. Medicare spending projections over the next 10 years are $2 trillion less than before passage of the Affordable Care Act. And I don't think anyone on this committee who sat through the deliberative process of putting the ACA together was fooling ourselves and thinking this was going to be the end-all, cure-all, be-all to all the ills and all the challenges that we face with the healthcare system that we have today. This is going to be a work in progress, and we knew it wasn't going to be easy. But the claim that we thought that this was the cat's meow and that every problem was going to be fixed with passage of ACA, I think is another form of self-delusionment that we have here today. So there are challenges, but I also know that in Wisconsin, we've got over 16 plans that people can choose from. We have an uninsured rate that historically is at an all-time low for our state. We'd be close to zero uninsured if our governor were to accept the Medicaid expansion money that he is selfishly and ideologically rejecting right now. We'd be knocking it out of the ballpark in Wisconsin. So I think there are some positive elements here that also need to be stated and acknowledged today. I yield back.
Thank you, Dr. Bustani. You're recognized.
Thank you, Mr. Chairman. I yield my time to Mr. T.
Mr. Bartold, point of clarification. The reason why we are doing this today is because the difference between, the question that Mr. Kind asked you, the difference between thus far in America, between health insurance companies on the exchange and co-ops is that health insurance companies that have withdrawn from the exchange have all withdrawn from the exchange after their contract period was up. The difference with the co-op, so everybody understands this, and it's very clear for the record, is that in my state, and what Mr. Smith talked about, there are co-ops in the middle of the contract, not at the end, no notice, just one day, Sally gets called and says, your insurance is canceled. You have no insurance. The plan's been suspended. So my constituent in Johnstown, Ohio, has no coverage to her doctor. That's the difference. Correct?
Mr. Tiberi, yeah, that was partly the point I was saying. I did not know what happens if another insurance company were to go bankrupt.
Well, that hasn't happened yet. That's the point. The point is,
but yes, I agree with what you said, that routinely plans are offered for the calendar year.
So Wisconsinites are lucky because they have 16 choices. In Ohio, if you had InHealth in some of my counties, not only did you wake up one day and you had no health care insurance, zero, none. You lost your doctor. Now you go look at the plans, there's one. There's one plan. In that plan, oh, by the way, the doctor I've had for the last 12 years, tough, can't do it. Oh, that deductible that wasn't that high, now it's pretty high. And so the incentive is, Mr. Becerra, not to have insurance. So now you lose your health care, you lose your doctor, and now you're going to get penalized. And this is hypothetical in some people's mind. That's offensive in my mind. I yield back.
I yield back, Mr. Chairman.
Thank you, Dr. Bustani. Are there any questions about the amendment, the nature substitute? Dr. McDermott.
Mr. Barthold, could you talk about risk corridors and what they were all about? Why you put a risk corridor into a program?
Mr. McDermott, I'm afraid I'm not prepared this morning to talk about risk corridors. If there's some specific questions you'd like my colleagues and I to address, I'll have to turn to that, but
because
I'm not prepared to do that this morning.
My question is whether or not when you are, I'm talking about co-ops, why did these co-ops fail? And the question is, well, did they make a mistake? Or if you open the door and a group of people come in, can you know when they come in exactly what the problems are you're going to face in the next year?
Some of the, as reported in the press, some of the financial stress on co-ops and on other companies has been you look at the mix of people that they insure, and if either by design or just by luck, they had a good draw in terms of health outcomes, and another company had a bad draw in terms of health outcomes. There are adjustments made in one direct, from the good outcome company to the bad outcome
So the company that opens the door and happens to draw the sickest people may be in trouble. Would that
They would be in trouble absent receiving an adjustment.
Okay. And the adjustments, if they're not given to them, the company then has to face whatever they have to face. And they could withdraw at the end of their contract period.
They'd be losing money. They may not offer the same plan the next year.
And the co-op had no residuals or assets that were set aside or anything else. All of them were just a group of doctors and facilities that put together a co-op, and then they misjudged who they got. Is that what we're saying?
I don't know the specifics, so I shouldn't say too much about that. There were, I do know some co-ops made efforts to get some reserve financing, but I don't know across the board. I'd have to do some more research with my colleagues.
What Mr. Kine raises is, I think, very important. If we're going to exempt people from paying the mandate because they lost the coverage they had, then we will be at the end of this year, when people are covered by private insurance companies that withdraw from the market, they will then be in the same situation. They will have lost their insurance coverage, just like somebody in the co-op. Whether it's at the end of the year or during the year, they have to go out and find somebody else. And now we could say, well, if as of January 1, 2017, if your insurance company withdrew from your market, you've lost your health insurance coverage, and therefore you ought to be eligible for exemption from the paying of the penalty. That would be logically correct, wouldn't it?
Mr. McDermott, what the legislation says is, if, for example, if you lose your coverage in 2016, you would be exempt from the minimum essential care requirement for 2016, but you would not be exempt for 2017. General rules would apply for 2017, and that was part of the point that Mr. Kind had made.
So they're
we're
going to have to go get insurance in January, and we're saying, well, we're going to exempt you for the 7 months before because you lost your coverage, right? Even though even if there's only one plan, that seems like that somehow they should get an exemption. Will that be true for somebody who lives in a state where there's only one plan and they lose their coverage in a second company?
If it's a non-co-op plan, no. The legislation only applies to
somebody who made the mistake of getting in a co-op.
Correct.
Okay. Thank you.
Thank you. Are there any other questions about the amendment of major substitute for Dr. Bartold? Mr. Buchanan, you're recognized.
Thank you, Mr. Chairman. I'll yield my time to Mr. Smith.
Thank you. I do want to add, number one, if Mr. Kind and Dr. McDermott are interested in perhaps exempting more folks than just co-opportunity victims, if I might use that term, we can talk about that. But there are real issues out there, individuals having to pay deductibles twice if they have to enroll in a new insurance program. We hear numbers tossed around about the number of people covered, the number of people not covered. I've mentioned to Pam from my district several times already. She's lost her coverage 3 times, and that original coverage had her pre-existing condition covered and so forth. But I wonder, has she been counted 3 times? I just tossed that out. I can't guarantee whether or not that she has been double counted or triple counted. But if the ACA is a work in progress, as it has been indicated today, I don't think, in good faith, in good conscience, we can levy a penalty of several $100s per person per year, and that's minimum, and expect there to be good
the gentleman
policy
yield?
and good patient behavior, taxpayer behavior following all that. It is unconscionable to me that the situation is in such a mess with coverages that are mandated perhaps, or premiums that are higher, co-pays that are higher than originally indicated. Let's stand back.
Will the gentleman
yield?
yield?
Exemption to
Mr.
occur.
Buchanan controls the time. And
Allow this exemption to occur, because people just seeking to do the right thing should not be penalized, especially the way it is structured. And I would yield my time back to Mr. Buchanan.
My friend from Florida yield? Great, thanks. To my friend from Nebraska, I think you had cited in your opening statement 2 individuals that you specifically worked with as kind of examples leading up to the creation of this legislation. But you also mentioned that with these individuals that you cited, that their situations were resolved with, quote, minimal disruption. I'm wondering if you could clarify what minimal disruption you were referring to.
Well, I don't have all of the details of what or how they responded, but I'll guarantee you that things would have been better had they not had to worry about the IRS levying a penalty in the process.
It just sounded like things did work out for them ultimately, given the options that they had chosen, but I wasn't clear what minimal disruption you were referring to. So I'll yield back.
Thank you, Mr. Blumenauer. You were recognized? No, sir. Mr. Dole, you're recognized.
Thank you, Mr. Chairman. And again, I'm listening to the conversation going on, and as someone that represents Illinois, where Land of Lincoln one of the co-ops just went belly up, and 49,000 Illinoisans lost their coverage. And so I've gotten calls and talked with constituents that, again, like Mr. Teaberry, find themselves without insurance and are scrambling to try to make sure that their family has coverage. And ultimately, what's happened is, as we see the premiums have risen, the deductibles have gone through the roof, they're in the process of paying thousands of dollars in the deductibles before they're hitting $1 of coverage from the insurance company. And then the plan goes belly up. And again, if they, like one of my constituents, Stephen, who's got 3 children, they're going to scramble to find coverage. And in Lake County, Illinois, like my colleague Mr. Teaberry was talking about, there's going to be one insurance plan. One person to have coverage up in Lake County, Illinois, which is a travesty as far as I'm concerned. But the problem is then this person's going to go back and start mid-year back at square one and have to pay the deductibles right from $1. And so he's already thousands of dollars into a health care plan without getting any coverage. And again, we're talking about a finite group. We've got 16 of the 23 co-ops that have already failed. We're only looking at those that have basically said, I was following the rules, I was signed up for a plan, I paid into the plan, and all of a sudden the rug got yanked out from underneath me. Please don't give me a penalty from the IRS for the rest of this calendar year. Now, they're going to be subject to it, according to this legislation, in the next year. But I have to believe we have to be somewhat compassionate for the idea that if they aren't able to find that coverage, we're not going to send them a tax bill at the end of the year for hundreds of dollars, potentially much greater. This is something where, again, 49,000 Illinoisans just lost coverage, and as of September 30 are going to have no coverage whatsoever. So this is something that's imminent for the state of Illinois, and frankly, I appreciate the work that my colleagues done on this legislation, and I believe it's a common sense step forward. This is not talking about completely changing things. This is talking about giving people an opportunity not to pay a penalty when they followed the rules all the way up through this process to this point. I yield back.
Thank you. Does anyone wish to strike the last word? Mr. Levin, you're recognized. This way.
Let me just say, those of you who talk about compassion, you starved co-ops for funding. You starved it. And now you're talking about people who may have to pay a penalty, and we don't have the data as to the special enrollment period, how many of these people were eligible for it, how many were eligible for the hardship exemption. We await that information. I just want to say, if you turn this into a major debate about ACA, and Mr. Teaberry, I understand your fervor. I just want to read to you the fact. Since 2013, before the introduction of Obamacare's core provision, the uninsured rate for non-elderly adults in Ohio has nearly been cut in half from 13.4% to 7.6%.
Will you yield?
Just let me just finish. And I just want to say what's true in Nebraska. You don't know how many people that you refer to had the opportunity to get a special enrollment provision, or how many were eligible for the hardship exemption. And when asked by Mr. Kind about these two people, you're really not even sure what the circumstances were for them. And I just want to remind you, as you talk about Nebraska, that 9,000 plus fewer individuals enrolled in Medicaid and CHIP compared to the number of individuals enrolled in Medicaid before the beginning of this whole program in Nebraska. And I just want to remind you, sir, I think I have this data as to Nebraska, as to the number of people who would have been covered if Nebraska had taken advantage of expanded Medicaid. And I'd like someday for you to tell me whether you were in favor of Nebraska taking advantage of that provision under ACA.
Will the gentleman yield?
Yes.
There is great skepticism based on how the ACA was rolled out and the difficulty with enrollment. There is great skepticism among the public that expanding the very program that has been under-delivering for a good while now.
Has been what?
The ACA in Nebraska, I mean, with higher premiums, higher deductibles.
I'm talking about Medicaid.
Exactly, but it is connected.
I know. Did you favor expanded Medicaid in Nebraska?
No, and based on the skepticism among the public.
You know how many thousands of people in Nebraska, as a result of your position, and those who were with you, how many lost expanded Medicaid coverage? My suggestion is, when you bring a bill and you talk about a couple people and you don't know what happened, we know what happened to the tens of thousands of people in Nebraska who did not receive coverage under expanded Medicaid. So I just suggest this. We'll wait for the facts in terms of the letter that we've written. And Mr. Bartold, we'll eagerly await these facts. I think you want to exercise your responsibility to inform this committee fully. We will also ask Treasury and HHS to give us these facts. And I just want you to know the facts include not only what happened to the co-ops and the people under them who were covered, but also the position of any of you who rise to talk about those who did not have coverage anymore because of co-ops, about the hundreds of thousands of people, in some cases over 1 million plus people, who do not have coverage today because of the failure of the state, often with your support, not to expand Medicaid coverage.
All time has expired. Does anyone else wish to strike the last word? Mr. Becerra, you're recognized.
Thank you, Mr. Chairman. I think Mr. Smith said something previously that I think all of us can agree with, and that was that people who are doing the right thing should not be penalized. And there would be unanimous vote in this committee if we had a bill that would essentially say to folks who are trying to do the right thing that we're not going to penalize you. I think Mr. Dole actually brought up an example where that could be the case, because if you have been paying your deductibles, your co-insurance, and all of a sudden your insurance carrier goes under, you made a big investment and all of a sudden they're gone. And if you have to now sign up for new insurance and start all over again, I think there'd be a lot of support in Congress to deal with folks like that, because they did the right thing. And it's not their fault if an insurer was not able to sustain itself and had to go under. But the difficulty with this bill, I say to my friend from Nebraska, is that it's a blanket shot. And my difficulty is that if we were facing this situation with auto insurance, if an auto insurance carrier went under and people who were getting insurance for their automobile coverage through that insurer all of a sudden found themselves without coverage, we would say to them, okay, so don't worry, we're going to exempt you from having to find auto insurance for the next 5-7 months because the carrier you had went under. Now, here's the point where I think I agree with Mr. Tieberry. You want to have options. You don't want to be compelled, forced to go into some place that you just can't afford. I don't think that's the case. That's what we're left with. So to me, this is an issue where, just like we would want to make sure that somebody driving on our roads and highways has insurance, and simply because the insurer you had went under doesn't mean you shouldn't still get insured.
Will the gentleman yield?
Sure, let me just finish the point. But what you want to make sure is that you're not penalizing the person who was doing it the right way. I think that's where you'd get a lot of support. But my concern is that there are a lot of free riders in America who want to get away with doing something that they think they can avoid doing, where other Americans are doing the right thing. They're playing by the rules. And I don't think what we want to do is say to somebody, because an insurer, that co-op went under and you no longer have your health insurance, that you should at least seek an alternative. And by the way, if you're provided with an exemption already, if it becomes unaffordable, economically it would be a hardship, we're protecting those folks. And so I think that's where, in the circumstance described by Mr. Dole, we would want to make sure that we're providing those folks with a hardship exemption. But I don't think what we want to do is start incentivizing people to not get health insurance, just the way I don't believe we would want to incentivize people to not have auto insurance coverage. But let me yield now to the gentleman from Nebraska.
I can appreciate the point you want to make about car insurance, but not everyone in America is forced to own and drive a car. And yet this policy is based on the premise that everyone has to do what the federal government says.
Right, but let me
if the federal government missed the mark,
let me reclaim my time.
Let me
reclaim my time and say this: that you're right. We're not. But what we want to do is change the mindset. If I'm 25 years old, I'm really healthy, athletic, I don't think I need health insurance until I get on my motorcycle and one day I get sideswiped by some car and all of a sudden I need a lot of health care. And if I don't have insurance, there are a whole bunch of American taxpayers who are covering my health care bills. And so what we're trying to do is say, let's not treat our health the way because we think we're going to be healthy for quite some time. Let's understand that health care is very expensive, and we want to make sure that we're not burdening other fellow Americans for our own health care because we thought we were invincible. And in this case, to Mr. Tieberry's point, it's not the fault of the Affordable Care Act that insurers are unwilling to give Americans affordable coverage. That was the case before the Affordable Care Act. That's why over 20 million Americans have secured health insurance through the Affordable Care Act, because before it, they couldn't afford whatever option, if there were any, insurers made available to them, including in the state of Ohio, including in the state of Nebraska, and in my state of California, which I know best because I live there. 2 of every 3 people who, before the Affordable Care Act, were uninsured today have insurance. 2 in every 3. There were 6 million Californians who did not have insurance. 2 in every 3 now have insurance. So that's over 4 million. Of the 2 million who don't, a good number of them don't because they're undocumented and they don't qualify for health care through the Affordable Care Act. So the vast majority of Californians have done it. I suggest, Mr. Tieberry, that you go look at your state and how it administers its health care programs, as Mr. McDermott was saying, and I think there you'll find the kernel of why folks in your state may not be getting the care that they need.
Mr. Tieberry, you're recognized.
Move to strike the last word. Thank you, Mr. Chairman. Mr. Becerra, I spent August traveling around my state in the capacity as the healthcare chairman. And I visited with hospital administrators, I visited with doctors, doctors' practices, patients, chambers of commerce, healthcare companies. Ohio is not much different than the rest of America. What's frustrating for me, Mr. Becerra, is when we walk into this room today, we're lectured about this is a hypothetical problem, when I have real constituents sitting across from me who don't feel it's hypothetical. It's a bit offensive to me. So I apologize. No, don't.
General, I'm not talking hypotheticals. I was talking real case examples.
I'm talking real cases too. There's no denying the fact that there are more people who have insurance today. But when I sat down where Mr. Pascrell sat during the Affordable Care Act, you all said we have a problem with people in emergency rooms who have no insurance, and this will help. Every single hospital I visited during my trip around Ohio, they still have problems in the emergency room. Now, people have insurance, but they have high deductibles. Now, I'm not disputing with you. I'm just telling you what I heard from hospital folks.
Mr. T-Berry, would you just yield?
I'm not yielding. No, I've sat there and listened to you.
Mr. T-Berry controls the time.
But you guys can't have it both ways.
Not asking for it both ways.
In Mr. McDermott's next life, I want him to help all of us in primaries because we're apparently more effective than our base thinks we are in killing the Affordable Care Act, according to what you all are talking about, what Mr. McDermott talked about. I mean, the reality is we have a system that for some people is working better, but for a lot of people is working worse. And you guys want to deny that. And here's how you're having it both ways. You criticize us because we want to repeal the Affordable Care Act. Then you criticize us for taking a small piece, which is what we're doing today, a small piece to give some folks who've lost their insurance some certainty that the IRS isn't going to go after them and tax them because they did something to no fault of their own. And then you wonder why the American people look at us like we're crazy. Now, we had a lovely hearing yesterday that you weren't at, and I think anybody on your side of the aisle who was there would agree. I didn't make one political statement about the Affordable Care Act, not one. Some of your members gave me plenty of opportunities to, but I didn't take the bait because I'm trying to rise above it, not for you or not for me, but for my constituents. And until we all in this room can start coming together and stop the politics of this, because healthcare is personal, healthcare is very important. I lost my healthcare when my dad lost his job. Now, I know you all think that Republicans don't lose their healthcare based upon the politics that we see, but that's the reality. And when I sit across from a lady who lost her health care, now adding insult to injury, is going to be taxed by the IRS when she lost her doctor, and I'm told and lectured that's hypothetical and that we're all, we hate Obamacare and we don't care, when we're lectured that we don't want to fix Obamacare, we just want to repeal it. Well, today we're trying to fix it. And some people in our party don't like the fact that we're trying to fix it today. And then to add insult to injury, as I said again, we're told it's hypothetical. That drives me insane. I apologize that it drives me insane, but it drives me insane. And until we rise above that, and if Mr. Pasquarello and I had dinner, we could probably solve this problem until somebody else, maybe from the leader's office, said, sorry, Bill, you can't do that. Or from my leader's office, sorry, Pat, you can't do that. But it shouldn't stop us this day from trying to come together and fix a small, teeny-weeny piece of Obamacare for the 22,000 people in my state and the 48,000 people in his state. I'm not debating that some people have better health care coverage today. I'm not debating that. What I'm debating with you today is there are people in my district, because of this law, aren't being served properly by this body. We can fix it in a bipartisan way, take the politics out of it, and stop arguing with ourselves. Yield back.
Thank you, Mr. Pasquarello. You're recognized.
Thank you, Mr. Chairman. And what starts off as many of us thinking as a marginal issue brings about, I think, some heartfelt discussion. I want to go back to what Mr. T-Berry just said a few moments ago. Mr. T-Berry said that until those of us in this room can come together, and I couldn't agree with him more. I don't think that he's talked about hypotheticals. I think he's talked about real cases. And I can agree with much of what Mr. Tiberi stated today, much. I'm not ready to vote on this bill right now, to be very honest with you. I don't believe we have some very cogent facts that I think are necessary. I don't think at this point in time, not that the description, Mr. Barthard, was anything but superb, but nothing in this bill responds to the specifics of Mr. Tiberi's thoughtful criticisms, as I see it. Now, maybe if we had more numbers and we could get answers to what Mr. Kind asked, it'd be a lot of different. No, look, things have changed. We could say, well, the solution to all of this is a public option.
Will you yield just a second?
Go ahead.
What does it hurt? What does the bill hurt? It doesn't hurt anybody. It just provides certainty for people who lose their insurance.
Taking back my time,
You can have your time back.
Tiberi, I think that's a very important question. I can only speak for myself. It's interesting that your response is, what does it hurt? I'm looking at what will it solve. I don't think it solves the bill in its present form. Solves what you think it does. We can agree, I think, what is fair. I think you want to be fair. I think Mr. Javier was very clear about that. When we judge all of these cases together and not specifically, then we're doing wrong. Because there are a lot of folks, and there are some folks, or a few folks, that want to ride the train for nothing. Now, the Democrats and Republicans over the last 3 years, through the chair, Mr. Tiberi, you know quite well, have talked about various health plans, most of which, I would say about 85 to 90%, always talked about a mandate. And it's a mandate that some of the folks on your side have picked out as good fodder. No one wants to be pushed to do anything. I don't want the federal government to do this. I don't want the federal government to do that until you need the federal government, until your water's over your head and you need the federal government. There is a place for the federal government, as Alexander Hamilton said. There is a place for the federal government. We should be working together, to go back to use your words, to strengthen the ACA. I've got 6 or 7 beauties that I think you might be interested in that I'd like to change tomorrow morning. I'm ready to put them in legislation. And I don't think that you're far off when you say we could sit down and probably work this out. Well, that's what we're trying to do here. I don't believe anything that I've heard today on either side is motivated by strictly politics on this bill. I don't believe so. Either side. Not just yourself. Either side. Now, what we're chipping away at, and many would perhaps think of this, that we're chipping away at the mandate. This is what we're doing if we pass this bill. I don't see us solving the problem, by the way. But which is essential. I think the mandate that is in the ACA is essential to balancing the risk pool and keeping premiums down. Now, we're waiting for the October surprise about premiums. You want to go back to the 10 years before the AC about premiums and how premiums rose? You want to go back to the many states in this union that had only 2 or 3 folks that were even selling insurance, health insurance? And we have a lot to learn, and we have a lot more to change. There's no question about that, Mr. Tiberi. I'm with you. And I think what you've made is some very, very important points today. I don't think we're ready to vote on this bill, though. I'm not convinced that we're ready to vote on this bill. And I ask you, and I believe what you say, that if people in this room have to come together on these things, because people's health are critical.
All time has expired,
all of
Mr.
us.
Pascrell.
Well, then let's put it off. I'm willing to vote on it before we leave.
All time has expired. Dr. McDermott, you're recognized.
Thank you, Mr. Chairman. I strike the last word. Mr. Preskrell raises an issue, I think, which is fundamental here. If you take the case that Mr. Harris has brought up, this woman in his district who's come to him and lost her health care coverage, there's nothing about this bill which helps her get coverage.
That's right.
This does not do one thing to make her position better.
That's right.
He lives in a state where his governor or the legislature or whatever has decided they're not going to take care of poor people. They're not going to expand Medicaid, which was offered by the ACA. So she is in no better shape when this bill passes than he's saying she might save herself some penalty. But if she gets sick, or her child gets sick, or she gets whatever, she has no options. She has to go down to the emergency room of the local hospital and put herself on the tender mercies of the people of Nebraska, who will pick up the cost of that uncompensated care. And Mr. Becerra raised that issue. Everybody gets care in this country. Some people pay for it, some people don't, and some people pay for other people's care. Every one of us sitting on this dais is spending an extra $1,000 a year covering the uncompensated care of people out there who are not paying for their insurance. That's what the Affordable Care Act was about, was to get everybody covered by insurance. Now, the reason there was so much calculated attack on the co-ops was they were a public option. They were not insurance companies. This committee defends insurance companies to the hilt. We put in risk corridors for them on drug options and everything else, but when it comes to co-ops, we take away any support they might need for going into a very complicated area. If you open the doors, like you open the doors of this committee room, you don't know who's going to come in here. And if it's a doctor's office, you don't know who's going to come in here. So a co-op doesn't know who's going to enroll in that co-op. It may be everybody who's very sick or has long chronic illnesses and they join the co-op. And then if they don't get any young kids, these 25-year-olds who are invincible, I remember when I was 25. You know, one of my college classmates died. I'm down in this morning, I was talking in the gym with one of my colleagues down there, a Republican actually, who told me the same story. When he was in high school, his brother's girlfriend died at 17. Young people get sick, and the cost of young people has to be factored into this. But if we let everybody out who figures they're invincible and they'll never get sick, we will never have a system that works. And I sometimes cynically sit back and say, I hope the Republicans succeed, because we're going to get single payer out of this. Because people are ultimately going to come to the government and say, fix this for us. Just like they do when we have a flood in Louisiana. When the water's 10 feet deep in a place that had a 1,000-year floodplain, they'd never had a flood, where do they look? They come running to Washington, D.C. with their hands out. Help us. Well, that's what's going to happen in health care in this country if the Affordable Care Act is not allowed to work and function. And that means keeping an individual mandate. If you let out everybody who doesn't want the government to tell them anything, well, you let out probably 50% of the people. You wouldn't have 50% of the people with automobile insurance if you put it up to a public referendum. Government has to step in and deal with something like this. And this bill isn't going to hurt anything. It isn't, we don't know who it's going to help, if it helps anybody. It's a good campaign bill, I got to say that. And I know this is the election season and I'm not running, so thank you very much.
Time has expired. Mrs. Smith, you're recognized.
I move to strike the last word.
Yes, sir.
I would just add, and I, in the interest of time, would prefer to wrap things up here. We're talking about a very narrowly drafted proposal. Narrowly drafted so as to keep the subject at hand as the primary focus. And I realize it's turned into a Medicaid discussion. I suppose that's fine. That's inevitable. I don't think if the solution to health care in America is pushing more people into Medicaid, some of whom would come off of private pay insurance. And if you talk to providers, they hardly believe that increasing the role within Medicaid, that's not really insurance anyway, but reimbursements are lower. So we might go from perhaps some uninsured folks, but certainly that pushes, with the expansion of Medicaid, pushes them into, I would say, an undercompensated plan. That's hardly a solution. But let's focus on this narrowly drafted proposal to help a small number of Americans, but nonetheless, many who have faced the loss of coverage so that they won't be fined and penalized by the IRS. Thank you. I'll yield back.
Thank you. Mr. Neal, you're recognized to strike the last word.
Thanks, Mr. Chairman. I think one of the problems that I've seen after all of these years in the House is that our institutional memory is frayed. There used to be a time where there was an element of goodwill as we discussed many of these issues. And when you read Ted Kennedy's memoir, one of the things that he laments as he knew that the end was near for him, he said, "I regretted very much that I didn't accept Bob Dole's offer on the mandate." He said that would have put us on a path to a sustainable health care reform in America. And then Governor Romney developed the mandate in Massachusetts and then ran for president and wanted people to think he'd rather be in a witness protection program than acknowledge he had developed the mandate in Massachusetts. So we go to the floor. We have voted how many times? 50 times to repeal the Affordable Care Act. Now, nobody questions Mr. Tiberry's sincerity as to the point that he's making. But let me use an example to contrast the reaction to the Affordable Care Act when I hear people say, well, some people have health insurance now. 20 million more Americans have health insurance now. But back to the point of contrast. So we opposed, as Democrats, Part D, prescription drug benefit, because we thought that it didn't go far enough. We won the majority, closed the donut hole, expanded the benefit. Today, it is accepted law, and it has worked quite well for the American people. Nobody even talks about going back and repealing Part D of the prescription benefit. Instead, we expanded the opportunity for more Americans to participate. That's the foundation of the health care bill. Instead, we go to the floor for this incendiary rhetoric where even the current candidate on the Republican side for president says he's going to get rid of Obamacare. And by the way, had one of the classic lines when asked by a reporter, what are you going to replace it with? He said, don't worry, pal, you're going to love it. And I think that's what we're up against today. Back to that notion of the institutional memory. The House used to function quite differently than it does today. I yield back my time, Mr. Chairman.
Thank you. Does anyone else wish to strike the last word? Seeing none, let me strike the last word very briefly. We've been asked to look at facts, and the fact of the matter is these co-ops aren't the victims. They took $1.7 billion of taxpayer money. They promised to deliver health care, and they folded. The real victims are the almost 750,000 families who are hurt by this collapse of the co-ops. Think about it. That's more than every man, woman, and child in 5 different states in America. This is a lot of people who are being hurt. And the fact that today this is about exemptions. When you think about it, just look at the facts. More than half of Americans in Michigan and California and Wisconsin have used exemptions to make sure they're not covered by Obamacare. It's worse in Washington. 3 out of 4 Washingtonians have found a way to get out of Obamacare in the exchanges. It's even worse in New York. Nearly 4 out of 5 New Yorkers have used an exception or paid the tax to make sure they're not in the Obamacare exchanges. And other than that not being a ringing endorsement of the miracle of Obamacare, it certainly raises the perspective on these exemptions. There are more than 20 exemptions. Some are guaranteed, some are optional. So exemptions are guaranteed to prisoners in America, but they're not guaranteed to the victims of the co-op's collapse. So prisoners, exemption guaranteed. The victims of the co-op collapse, maybe. Good luck. It depends. So it seems to me, as Mr. Smith has proposed, a very narrow exemption to victims of the co-op collapse for the balance of that year seems only fair. That ought to be guaranteed to Americans who have hurt by this. So rhetoric aside, this seems to me to be a very simple, very narrow, very fair help to people who thought they were buying something they could count on and didn't. So with that, are there any amendments to the amendment in the nature of the substitute? If there are no amendments, questions on the adoption amendment in the nature of a substitute, all those in favor signify by saying aye. Those opposed, no. In the opinion of the chair, the ayes have it. Amendment in the nature of a substitute is agreed to. I'll now recognize Mr. Teaberry for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 954 is amended to the House of Representatives.
Questions on favorably reporting the bill H.R. 954 is amended. All those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it. The motion is agreed to and H.R. 954 is amended. Is order favorably reported to the House without objection. I ask the staff be authorized to make technical and conforming changes to the bill. The members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. There being no further business before the committee stands adjourned. You'll excuse me, the meeting in committee has adjourned, but we will maintain order in the room as we exit. Thank you.